ever worth a reprise. Let's see, we got a lot of people over at Wilford Hall that I don't recognize. I'm Daryl Baskin. I see Madsen, the family practice doc, and there's a guy in the back left corner. I don't know his name.
That's Tim.
Tim the pilot.
Yeah.
All right, so don't ask him questions.
Yes. Dude.
Oh, he is.
He's smart.
He's a resident.
He's smart.
Oh, okay. All right, good. More than most residents. Nice. That's what residents like to hear. All right, and then there's somebody with glasses over on the right.
That's John.
John. Okay, I'll just point at somebody and tell me their name. We'll ask them a question. We won't pick on those guys. We'll just pick on you. This is going to be on retinal emergencies, but as I thought about, there really aren't any retinal emergencies. There's nothing worth getting out of bed for in the middle of the night, except maybe endophthalmitis. So this is mostly going to be kind of what I consider to be a crash course. I know you had a lecture last week with Dr. Hardeleza, and I wish I had sat in on it because hopefully I won't go over too much of what she did. If I do, just kind of go like this, and I'll go to the next slide. And then we're going to talk about some common stuff. Thanks. I don't have any financial conflicts of interest except those of the American taxpayer, which actually are a pretty interesting conflict of interest, but we won't go into that in this one. And then I may talk about off-label uses. And I may say totally the wrong thing, but if I say something that disagrees with my slides are probably right. So we'll talk about some emergencies and then some commoners. All right. Oh, yeah, I guess they should be able to see the slides, right? And there we go. All right. So what is an emergency? It's a serious situation that happens unexpectedly and demands immediate action. And the reason I put that up there will become apparent soon. So let's see. Luke, you're right in front of me. What's the image on the left show?
Hemorrhagic, swollen disc.
All right. Chris?
It's like an optic nerve head avulsion.
All right. Good. Sorry, Luke.
I've never seen
I'm just playing. I've only seen a handful myself. So we've got an optic nerve avulsion on the left, and what do we have on the right, Dr. Hager?
Looks like a intraocular foreign body associated with a perforation.
Correct. At least it may not actually be a perforation, but it could at least be some sort of penetration. So which one is more of an emergency? Dr. Parlin.
I'll go with the tear.
Good. I'm assuming you mean the one on the right. No slides? All right, hold on. Let's see. You guys probably know this better than I do.
Oh, we don't know. It's new. We don't know anything new.
All right, what does this thing do? Can you see him now? No. Negative.
Do you guys mind calling or texting UT and see if they have it? I can see on their screen they don't.
You can tell that they don't?
What's the number for VTC?
All right, what does this button do?
Down there.
Do I need to click through these? Equal, prominent, over. These are just different. That's not very helpful.
Yeah. Figures on the bridge.
Call the bridge. How do they get the name The Bridge?
Bridge.
They must have all been like Trekkies or something, you know?
They can hear you, by the way.
I'm sure they can.
Okay. I just because we've made the mistake before.
Talking bad about them. Nice. They're like, whoop! Somebody said bridge. That's hilarious. All right, we'll go with prominent, and they probably don't see it yet. What does this button do? Nothing, 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 nothing. Did I do it? Do you guys see it? Nice. All right. Well, I'm not calling on you guys, and I can't see anybody now. So
How did you do that?
I pushed this button that said PC. I guess it correlates to this bottom right. Okay, let's move on. So IOFB. You got your CATS mnemonic. This is, again, mostly for you guys that are first years and some. Everybody here's a resident, right? Okay, good. So CATS mnemonic, also known as, done as FART, but we'll do CT orbits, antibiotics, tetanus shield. This is all hopefully review. And then in this case, this is an unusual scenario where somebody actually was playing basketball, had a finger go into the eye, broke their lamina propria, and that popped into the eye. So this wouldn't be one that you'd actually close. You'd actually want to call a retina person first. But usually if there's an IOFB, there is an injury that needs to be repaired by whoever's there at the time. It's anterior or wherever, and then you call the retina person. But it's never that wrong to call the retina first. you just might get yelled at. No effective treatment. That's why this isn't the emergency, right? It's like, you know, somebody who gets decapitated. It's really bad and it's awful, but there's not anything you can do about it. Okay, so now, where were we? We've got Michael. What do you see on the left side?
Colored fundus photograph with some.
Oh, hold on a second. We got two people answering at once. Sorry, Wilford Hall. Are you guys asking a question or answering mine?
No,
There's a Michael there.
Michael Madsen.
Oh, sorry. I'm asking the guy with the last name Michael. That's going to be really confusing. Madsen, you're off the hook. Everybody at Wilford Hall, you're off the hook. Sorry, guys. It's not that I don't like you. All right, so you said color fundus photos, right, so far.
And then it looks like there might be a serious detachment of the retina.
Good. So there's something under the retina that's kind of whitish or yellowish, and there's some pigment down close to the fovea, right? And then what do we? And do you know what that diagnosis is? It's a tough one. It's actually, I'm looking just for a category. We'll call it outer retinal whitening. And then on the right, let's see, who do we have? Lutmer. Just describe colors if you want.
White, there's a white portion superior to the macula. It looks like.
Rich. All right, so some white stuff in the macula, and then I'm going to ask Tamana. It's tough from there, but I can't really get the cursor to show up. But you can see that one of the arterioles coming off of the disc is a little bit obscurated by the white stuff. So these are a bunch of cotton wool spots. So, Tamana, which one is more of an emergency? This is somewhat of a subjective question, or at least the answer is.
The cotton wool spots, if they don't have any other reason for why they should have it.
Well, there's always a reason, right?
Well, if you don't know the underlying etiology, then.
All right. Okay. So which one do you say? Cotton wool spots?
Yes.
All right.
If they're not a known diabetic or anything like.
Okay. Well, I disagree, but I'll tell you why I disagreed. So in this case, this is outer retinal whitening. So there's a workup here, right? So you see this patient in clinic, and before you come get one of us, you want to at least be thinking of what you're going to order. What are some things you might want to order, Dr. Powell? Just throw some stuff out there. There's a bunch of stuff.
CBC.
Right? That's the first one on my list. Good. CBC. One other thing, and then we'll just show you what I've got.
HIV.
Good idea. And I didn't write it in there, but I do agree. I should have had HIV in there. Do I? Yep, I do. Good. I just didn't have it in the right order. So this is outer retinal whitening. It's concerning for a lot of things. The most concerning to me, potentially, is, does anybody want to guess? ARN. Syphilis is a big concern, but ARN is going to move really quickly. So they're both devastating. ARN isn't going to kill you. Syphilis potentially could kill you if you... Anyway. So,
question, sir. What's ARN?
We're actually going to get to that one later, but acute retinal necrosis. The reason I put these in here is these are not very common things to see, but when you see them, you need to kind of have your hackles raised. You don't want to see something like this and say, I'm not sure what it is, but, we'll have fluorescein it tomorrow morning, and we'll just have you come back tomorrow. This is actually something where you want to call your third year. If he doesn't or she doesn't know, call the retina person in the middle of the night. This is the sort of thing, if it were my eye, I would want it treated pretty quickly. So even though this is actually acute syphilitic posterior placoid chorioretinitis, which has a nice little mnemonic, which I won't say, it also could be progressive outer retinal necrosis or acute retinal necrosis, which can, as the name suggests, be very bad. So you want to test for those things, but I'm actually going to start them on treatment before I get results back for intravitreals, and then I'm going to start them on Valtrex. So CMV is not going to be really treated by Valtrex, but it will be treated by the ganciclovir foscarnet. But progressive outer retinal necrosis, number one cause is varicella zoster, and acute retinal necrosis is also varicella zoster, and then HSV1 and 2, and then CMV. But this could also be syphilis. It could also be sarcoids. You want to test for those things, get a chest X-ray. Obviously, if it comes back they have syphilis, they don't need to stay on acyclovir. And the reason I get HIV is that even though this looks nothing like HIV retinopathy, people that have syphilis sometimes also have HIV. So that's why you want to test for it. So cotton wool spots, you want to get a history. What kinds of things do you want to ask? Tamani, you mentioned a couple. Diabetes,
hypertension,
right?
Sort of underlying cancer.
Right. Did they have radiation? And do they have GCA symptoms? GCA is a big one because you may not think about GCA when you see cotton wool spots, but you should ask about it, especially if you don't have another cause. And then I put oral ulcers in there because Behçet's, right. Yeah, exactly. And so let's keep on going. So the workup is very similar to the last one, but you want to check a blood pressure for sure. Look and check an ANA. Now, if they have GCA suspected, you got to do the ESR-CRP and then consider doing a TA biopsy. If you think it's an embolic source, then you want to go down that route: carotid Dopplers, echography, and echocardiography, and then blood and urine cultures. So things to think about. Again, this is just you in clinic, and pretend like all the staff died in a plane crash or something, or got shot down over Ukraine. Okay, so we'll go back to you. What do you see on the left?
A cherry red spot, or the other one.
Yeah. Cherry. I know it's weird because it's like it's the right eye, left. So we'll just say left picture. I'll probably get them mixed up. So on the left, we see a cherry red spot concerning for CRAO, and obviously there's some childhood conditions that can lead to this, like Tay-Sachs and that sort of thing. But that's usually not when they come in 80 years old and acute vision loss. Okay, on the right, what do you see? What's
blood
that?
and thunder.
Good.
More concerning for CRVO.
Good. So we got CRAO, CRVO, right?
No,
So
it's supposed to pass.
yeah, he's still your thunder.
Yeah,
All
I
right.
hope
So
he-
which one's a more emergent one, Chris?
The CRAO is you can't really treat it. You can try.
Well, so I
that
disagree
do?
with you, but you're right. You can't really treat it. You could try, but it might be indicative of something that's a graver disease.
If you're concerned for GCA.
Exactly. So sometimes it's an indication of something really bad. I mentioned that guy who got beheaded. If he got beheaded or decapitated in a car wreck, not an emergency, but if he's decapitated by like a serial, like medieval night killer, that's a big deal. That's emergency because you want to stop that guy. So this is that kind of thing where there could be something else going on. Yeah, I should stop using that analogy. But anyway, so GCA suspected, order it. Again, here's the things you want to check. Very similar to our last one with the cotton wool spots, but also consider hypercoagulable panel if they're younger, and you'll see a similar theme on the next one. Carotid Doppler, EKG, TEE, TTE. Most of the stuff is from Will's. Some of it's from the book, and then some of it's just stuff I put on there because I get to make these slides up. So consider an FA, and there's no proven treatment. There is a stroke protocol at some tertiary eye care centers. I think Duke has one. So if they catch it within 90, 120 minutes, they may actually go out to a few more hours. They will actually, I think they put TPA, they cannulate and do things like that. But we don't have anything like that here. So we basically, I've never seen one within 120 minutes except for once in residency, and we sent him down to hyperbarics. His vision got a little bit better, but not a lot. So those guys love to do it. So if you catch somebody early, we do have hyperbaric oxygen. Send them down for that. Even though the data is really kind of squirrely, it's if it were me, I'd want to try it out.
We're always taught that it takes like 5-6 hours for you to have any ischemia or changes, edema, and so forth. What in the first primary like CRAO, is it just acute vision loss that's painless? Like what if you don't see a plaque and you don't see any changes in the retina? Like
You're saying, say that again. I'm not
how
sure
are
if I
you
understand the question.
diagnosing CRAO?
You're saying if you don't see this,
Yeah, because you don't usually
get
see
an
it.
FA. You do sometimes see this.
Okay.
You're right. Your retinal whitening may not show up instantaneously. And there was a case at Wilford Hall maybe a year and a half ago where it was like, I'm not really sure what it is. Get an OCT, get an FA, and come find one of us.
Okay.
But if they have acute vision loss and you don't have another reason why, you should always come and get a staff, right? What's that?
It's the middle. I mean, I had something similar. That it was in the middle of the night. I couldn't get the FA.
Well, that's
so I brought
a
her back
really.
first thing in the morning.
And then it
but-
showed up like this.
No,
Still did.
we like did temporal artery biopsy on both sides, and everything's been negative. But she went NLP in one eye and lost half her vision in the other eye.
I don't know if I have a good answer for you then, especially if you never confirm the diagnosis. You're right. What if it is the middle of the night? Well, we don't have a stroke protocol here anyway, so it's kind of one of those. We don't have much of a treatment that we could do. So you could try the paracentesis, IOP reduction, and hyperventilation if you wanted. I haven't. Again, the one guy I had, we just sent him down to hyperbarics. You could just call hyperbarics up and see if, hey, this is on the differential. It's on the top of your differential. See if they're willing to do it. Get an FA in the middle of the night is tough. Okay, CRVO. There are a few other things that you should think about. Obviously, this is obviously CRVO, but if it's kind of mild, what are some other things that can look like this? Where are we, Dr. Hager?
It can look like Well, I mean, diabetic retinopathy.
Right. Good. That's a good one. That's a big one. Dr. Parlin? Oh, man. Anybody else? We got like 2 or 3. Yeah, radiation retinopathy.
Ocular surgery.
Perchers. Yeah, Perchers. I didn't put it on there, but yeah. And then Terson's. That's more of a. I like Tejano though. The Tejano.
It's all association.
That comes in later, but that's vitreous hemorrhage, right? Okay, good. And then ocular ischemic syndrome, especially if they get like a venous stasis retinopathy, some tortuosity. If you dot blots, you just put it in the differential. Ocular ischemic syndrome doesn't give you the tortuosity, it just gives you the dilation, and then you get the peripheral dot blot hemorrhages. An FA will be helpful. You want to look for NV because by the time they present, they might already have NV, especially if they present late, obviously. FAOCT, and then you want to check a lot of other things. Especially if they're younger. I don't check all these things in my older patients that have a lot of risk factors, I have to say, so I should probably adjust my own protocol a little bit. But if they're younger, I'm always going to send them to HEMONC. I'm also going to get a sleep study. I think that's my next bullet.
Sir, because I got myself in trouble one time I had a CRVO come in and I ordered an ESR and it came back high.
Yeah,
and Dr. Kim's like, so why did you order that? And I was like,
I debated putting that at Will. Exactly.
I have no idea why it's there.
So it's in Will's, and I put it there, and I thought about deleting it last night. I have the same issue that if they don't, ESR for me is only helpful when it comes to GCA, although obviously there are other entities that raise an ESR. If they don't have GCA symptoms, I would be hesitant.
So he made me repeat it, and it came back negative, thankfully. And it was like, I mean, if you order something, we have to know why we're ordering
right.
it. And if there's, even though Will says it, like.
You can't just say Will's told me to.
Yeah.
When we were first years and there was no third year to check out with, we'd sometimes tell the patient we're going to go check out with Dr. Wills.
That's awesome.
But it will sometimes get you in trouble. Okay, so treatment, we're not going to go into treatment. There's a lot of stuff we could talk about here based on neovascularization or macular edema. We don't just treat these because they're there. They have to have one of those complications. And, the treatment can involve a lot of different modalities. You want to follow up every month for at least 6 months. Look for NV. Okay, so I have no idea where we were. Dr. Michael, what do you think this blurry picture on the right is showing you? There's one part that's in focus, if you can tell from there.
There's a PVD.
Right, a Weiss ring. And then, let's see, Dr. Lutmer. What is that on the right, or what do you think it might be? There's a couple vessels you could see, a little bit of first order vessels, maybe second order superiorly. There's a disc kind of in the center. Could be. It's a vitreous hemorrhage. Right, so it's a really blurry photo. And Dr. O'Day again. Which one's more emergent?
Vitreous hemorrhage.
I kind of said either one could be emergent. Okay, so we're going to talk about the likelihood of a retinal tear. So if you have an acute symptomatic PVD, Will says one thing, book says another. Dr. Powell, what do you think? All comers, they come in with acute symptomatic PVD. What's the chance that there is a tear? Not that you'd find one, necessarily. Not that you can't find one. Just all comers, like don't know if they have a hemorrhage or not. You just, Dr. Gross says, I've got a patient with a PVD that's just started yesterday.
I'll go to 10%.
Okay, so 10% is what one thing says. I like 15%. Some people actually say 20%. So 15%. Now let's say they have a hemorrhagic PVD. What are the chances of having a tear somewhere?
About 60, 70%.
Right, so 50 or 70%. And Dr. Rodriguez, if they don't have any hemorrhage and they have a PVD, what's the chance that they have a break somewhere?
Wait, so that it's non-hemorrhagic?
Non-hemorrhagic.
Is that not the same thing as the first line?
So the first one is just acute and then includes everything below it. So hemorrhagic, non-hemorrhagic. That's like a subcategory.
Like you just find it in general clinic?
They come in.
No, they come in. They have an.
They were never symptomatic.
No. Not.
That's what I think. Yeah,
they're all symptomatic. Sorry.
It's kind of confusing.
So straight from the book. It's not confusing.
It's not confusing.
They have symptoms and they don't have a hemorrhage.
Oh, both of them combined.
Sort of, yes. I'm not sure what that means. Both of them combined.
25%.
Okay. Well, no. It's lower than 15. If they on it,
I don't think I understand the
all right.
difference.
Let's stop. This is good. I don't know if this is actually going to help anybody, but let's say Tamana has a PVD and so does Marion, and then she has blood and he doesn't, and then there's hundreds of other people just like them. Averaged together, 15% of them have breaks. But if you take all the bleeders and put them in one category, half of them are going to have breaks, and then you separate all the non-bleeders, 10%.
So the acute symptomatic
includes all those guys.
includes all of
Everybody
it.
comes up with
I thought that meant acute without hemorrhage.
Me too.
We're working on a statistical study together. I am slightly concerned. Okay, so this one's not in the book, but I had a patient that had a PVD and had lattice and wanted to know what her chance of having a tear was. Does anybody know? Is it higher or lower? It's higher, right? What's that?
30%.
I actually don't have a percentage. I have a risk ratio of compared to non-lattice. It's from a Thai study, THAI. So, not Taiwanese. Nobody thinks that's Taiwanese, but I went out to eat. This is a really sad aside, but we were eating at a Thai food restaurant with some, this is when I was single, a few guys, few girls, and one of the girls looks at me and goes, "This food is so delicious. What country are they from?" And afterwards, I thought, well, maybe she was debating between Thailand and Taiwan. I was trying to give her some credit. She's from Texas A&M, so and she had graduated. So anyway, sorry. Okay, so and I grew up in College Station before I moved to West Texas. All right, so PVD plus lattice 6 times more likely according to the Thai study. Again, you don't multiply 15% by 6. You have lattice and non-lattice and average together. That would be 15%, assuming they were looking at the same patient population, which they weren't. Now we lost somebody. All right, acute PVD, no tears on exam. You finish your perfect exam, and let's assume you didn't miss anything. They have no breaks. What are their chances going forward of getting a tear or of having a tear develop? Anybody know? This is in the practice pattern or preferred practice guidelines. What's that?
It's like 2 to 3%.
Yeah, 2 to 5%. So that's something you could tell them if you believe in your exam. I don't even know if I trust my own exam.
2 to 5% over a lifetime?
No, like the next 6 weeks or something.
okay.
So you could say over a lifetime if you want. All right, so let's break down vitreous hemorrhages by cause. I thought this would
When
be
you
interesting.
said non-hemorrhagic,
Great.
does that have anything? Schaefer's?
It doesn't have anything to do with Schaefer's.
So you still okay?
So you could still have a Schaefer's, I think. But that's kind of splitting hairs. Can you close that door a little bit? Okay, so vitreous hemorrhage. The vast majority of vitreous hemorrhages are related to, I don't know where we are. We'll go with Dr. Parlin.
Retinal tears or detachments.
You're really close. Anybody else want to guess what the number 1 cause is in San Antonio? What's that? Did somebody say AMD? Okay. Okay, good. Like AMD, nope, definitely did not say it. No, so diabetes. Yeah, the sugars. All right. 12 to 17% is the retinal tear without a detachment. 7 to 10% is a detachment. So detachment by itself, as you guys, with a tear can cause a vitreous hemorrhage. That's a no-brainer. And then 4 to 10%, this is our smallest category, are retinal NV from retinal vein occlusion or retinal arterial occlusion, so vascular occlusion of some sort. Okay, so, and then when you have a vitreous hemorrhage, just a couple of nuts and bolts things. You want to do an ultrasound. You want to look at the fellow eye to give you a clue as to which one of those it might be, or if it's something totally different. Peripheral NV is a long list of unusual things, and any one of those can cause a vitreous hemorrhage. I had a run of patients in fellowship that had vitreous hemorrhages with mild diabetic retinopathy in the other eye that all ended up having polypoidal choroidal vasculopathy, which is unusual. Usually it's just a subretinal kind of bleeding or sub-RPE bleeding. So there are weird things. Tejano syndrome or Terson syndrome. Kids, you got to think about a few other things, right? What are some of the things you learn about for testing purposes with kids? No, just for vitreous hemorrhage.
I know.
Not as common. What's that? Did you say something?
JXG.
Yeah.
That's
No, that is
JX, juvenile
I
X-linked
knew some-
retinoschisis,
Yeah.
right? That's one of them. They get their NFL, their nerve fibrillary peels away from the retina. When it does, it could tear a blood vessel. So they're called vitreous veils, but they tear enough, they cause vitreous hemorrhage.
N18.
Yes, not a top cause, thankfully.
What's not accidental trauma?
Shaken baby. And then, so the classic 3 that I learned when I was a resident: trauma, juvenile X-linked retinoschisis, and pars planitis. And it may not actually be blood. It just you may think it's blood. So, and then if you want to, something we did in fellowship again, we had one of the older attendings actually had a bilateral patch for a few hours, had them sit like this, and then re-examined a couple hours later, and they actually got a better view. So something to think about. I know it's
So just to keep them from
right. Their eyes aren't going to move as much, and if they don't fall asleep, you know, it's one thing just to elevate the head of their bed, but if they watch a tennis match, it's not going to help very much. So bilateral patching. So, okay, speaking of shaken baby, we see that on the right or left? Yep, our right. And on the left, what do you think that is? Yep, that's what it is. I called it zone 1. It could be zone 2. I can't really tell. There's probably plus disease that looks dilated all the way back. Shaken baby syndrome or non-accidental trauma, or they have another one that's like neurotrauma PD something or other. They keep on renaming it. I guess they want to be able to tell the parents what it is without them actually knowing. Your baby has gnats. No. Okay. So, which is more emergent? You know, they're both a big deal. Now, the one on the right is not very treatable, but again, it's that serial killer thing. You want to catch the parents. Not that they're going to shake out other babies, but you need to stop them from shaking this baby, I guess. All right, so we'll talk about this one. Get a thorough history. If you see these multi-layered retinal hemorrhages, pre-retinal, intraretinal, and subretinal, that's very concerning. It's this weird sort of rapid acceleration, deceleration, repetitive sort of trauma. It's really hard to do that, even in a car accident. Even if like major resuscitative measures are taken with CPR, you can't really cause that, okay? You do need to worry about things like leukemia, maybe Terson's or something like that. But again, this is a very specific picture. There's not very many other things that can do this. But again, you need to cover your bases. Get a photograph. You might be called to testify at some point. You want to alert pediatrics if they're not already admitted, get them admitted, social work, etc. For ROP, this is a whole lecture unto itself. In general, your screening recommendations are going to be if they're less than 1,500 grams, less than 30 weeks, or if the neonatologist thinks that they have an atypical course and they're 1,500 to 2,000 or greater than 30 weeks. Treatment is somewhat controversial as well. Laser was the old standard of care after CRAO, and now we talk about anti-VEGF, which can be used in mono or combination therapy, but we'll move on from there. Okay, we alluded to these entities before, and unfortunately that little box that we had, the picture in the picture is blocking our view of the right eye, but the one on the right. So the one on our left, does anybody know what that is? Bunch of outer retinal whitening in the macula. Could be CMV, right? In this case, this is a case of progressive outer retinal necrosis, but CMV could look a lot like this, and it should be on your differential. With CMV, I don't have one on CMV in here, but you have these 3 main categories, and one of them is that sort of pizza pie kind of fundus sort of thing, or ketchup and cottage. They have all these weird things. Brush fire brush fire border. That's one of the other ones, but you do get this kind of along a retinal vessel. You'll see a lot of whitening, and you'll see a lot of bleeding as well. And then on the right, we've got acute retinal necrosis, which you can't tell because I blocked out part of that peripheral whitening. Again, for the first years, both of these can be very, very bad. If you see white in the retina, besides like a small cotton wool spot or myelinated nerve fiber layer, you need to let somebody know. In general, acute retinal necrosis is peripheral. It's a scalloped appearance, and it becomes confluent in 360 degrees. It's lots of little tiny dots sometimes at first. It can also show up posteriorly. I've had a couple of cases where it was in the macula, and it behaved more like acute retinal necrosis than progressive outer retinal necrosis. But the main thing is that these need to be treated pretty quickly. They can go on to detach and lose a lot of vision very, very quickly. So if I suspect ARN, even if I suspect syphilis and other things, I'm going to do an AC tap. I'm going to get PCR on the herpetic viruses there. And then I'm going to do ganciclovir or foscarnet intravitreally and then get them on Valtrex. Some people admit there's nothing wrong with that. But Valtrex, assuming they're healthy enough to digest it and eat it, has got great bioavailability. You want to follow very closely. I'll repeat the intravitreal injections as well. And then progressive outer retinal necrosis, very devastating disease, worse than acute retinal necrosis. You want to check their immune status. Usually they have some kind of immune compromise. Same thing for CMV retinitis. There are cases of CMV happening in non-immunocompromised, but that's the exception. So you want to follow these people closely. All right. So fortunately, this probably hasn't happened to any of you guys. What do we see in these pictures? I mean, the one on the left's awful, obviously. The one on the right has a little hypopyon, so what do we call that? Endophthalmitis, right? So this is endophthalmitis with an open globe. I think this patient had a PK that opened up and was really bad. So, Tamana, since you've been answering all the questions, which is more emergent?
The open globe. Yeah, the open globe, I guess. That's
dead.
That one needs an enucleation
That's-
or
okay.
evisceration.
Yeah.
I'd do enucleation, but maybe somebody we could try to fix it. But the likelihood of us being able to help this person is very low. That's how I picked it anyway. So for this one, I try to follow the EVS. Some things have changed, and we talked about the EVS a couple weeks ago with a few of the residents and me, and basically they didn't have what's that?
They called one of us.
Okay. And so they evaluated some oral or IV antibiotics that didn't find any benefit to them, but they didn't have any third or fourth generation fluoroquinolones. So we do know that the intraocular penetration of moxifloxacin is great. So I do think it's reasonable to put people on that. They also injected different antibiotics. Now we do vancomycin ceftaz if there's no allergies. And then the cutoff for doing a PPV versus a
He'll be right here.
tap and inject is based on vision, right? So if their vision is what for a vitrectomy? LP or worse. And I would say if they're diabetic, they did better with a vitrectomy if they had better vision than that. And then if they had some other cause of their endophthalmitis besides acute, within 6 weeks after cataract surgery, such as like if they had a blebber trauma, then I would consider vitrectomy as well. So anyway, again, that's why we follow with a grain of salt. I think it's one of the best studies we have, but things have changed since then. So we're going to talk about some more common entities that we're doing pretty good on time. Okay, I'm going to stop asking people, but this is a kind of a blurry picture on the left. This is a patient with wet AMD, and the other eye had a lot of drusen. I don't know why this eye doesn't show as many drusen. And the one on the right is diabetic macular edema. So which one's more urgent? We'll ask Dr. Parlin. Good, exactly, it is. How quickly, Tamana, do you want to refer a wet AMD patient for treatment? Yes. Okay, so ideally that day if you can. I would say if you can get them to a retina person or get them treated within 1 to 3 days, that would be great. There is no standard of care right now that I'm aware of. They may have come out with something that I haven't heard. So in the old days, wet AMD, like 10 years ago, gosh, old days are getting further and further back. But we'd laser these things. The macular photocoagulation study. When I started out my residency, that was still the standard of care. Fortunately, I didn't have to do that to anybody. Because we could keep them from getting that much worse compared to natural history. So anyway, but the point is that you want to get them treated soon. Why is that?
I mean, you can get it better, you can prevent it from getting worse.
What is the anti-VEGF doing that is that has some time constraints to it? Anybody know? So VEGF used to be called vascular permeability factor. So one of the things it does is causes a lot of permeability. So VEGF causes blood vessels to basically lose fluid. It also causes new blood vessels to form. And then it also is a protective factor for vessels that are already there, which is kind of a weird one. So anti-VEGF goes against all those things. But once a vessel is mature and I think has pericytes growing around it, then it is pretty resistant to anti-VEGF. So I don't know how long it takes for a blood vessel to go from brand new baby blood vessel to I'm a big blood vessel and you will not mess with me kind of status. But that is one issue why you want early treatment. The other one is if they're continuing to ooze blood, that blood is toxic to the retina when it's under the retina, and you want to stop that. Anti-VEGF does not dry up blood in and of itself. It doesn't have like little macrophages injected with it that go and clean up blood. So what you want to get timely treatment, and you want to make sure that the patient knows what's going on and is educated. I've had a few patients when we go into this that have been, not from any of you guys, thankfully, have been referred to me, and they said the note said follow-up retina within 8 weeks. And those patients all lost vision permanently. I couldn't help them very much. I mean, I tried, but didn't help them very much. All their fellow eyes ended up getting involved, so I helped them. Okay, repeat every 4 weeks until dry. This is my protocol. T&E, I'll go out to 8 to 10 weeks, assuming I feel like I'm still doing them some good. Once they're below count fingers, or count fingers or worse, I really question whether I'm doing them much good. Again, that's another topic. AREDs too, they still have dry AMD. Even if they have wet in both eyes, they still have dry AMD. They still have the potential for geographic atrophy, which is sometimes the limiting factor for me. So I will introduce them to AREDs too, and I'll make sure they're off of their vitamin A. So lutein, zeaxanthine, omega-3 fatty acids were found to be good, bueno or no bueno for AMD?
Good.
No bueno.
Omega-3?
Omega-3s were found to not help. They probably help a lot of other things. They do not help wet AMD or dry AMD. So we found that out in AREDS 2 last summer, and I've subsequently told
The
everybody.
book still definitely says it potentially.
Well, we all thought it did. I've got a great study saying that omega-3 fatty acids do not harm the retina in AMD. It got it in archives, thank you, for JAMA Ophthalmology, 2013, if you want to look it up.
So they don't help, but do they harm?
They do not harm. My study showed that based on ERG, not my study, mostly Adam Gersten Bliss that I helped start, but they don't help. They neither help nor harm, and if you don't mind a fish burp in the middle of the day, they by all means go ahead. Also, but they probably have some benefit for blood vessels and the systemic circulation, right? So they probably are not harmful to anything except your wallet and your breath. So I also, again, another topic we don't have time for, if somebody's taking aspirin, that does double their risk for wet AMD. Okay, doubles. So if they're taken for primary prevention, the FDA recently came out and said they do not recommend aspirin for primary prevention. Talk to cardiologists. Primary prevention is a little bit fishy because they can take a Framingham score and taking things like diabetes family history. My brother died. All 5 of my brothers died at 45 from heart attacks. Yes, you haven't had a heart attack or stroke, but you probably should be on aspirin. But even for secondary prevention, the data is a little bit underwhelming. 8.2% to 6.7% is a benefit you get in reduced annual incidence of strokes and MIs. So not a big deal. And if you're taking a primary prevention, higher risk of GI bleed, brain bleed, and you have a 0.02% improvement over strokes and MIs.
But this is for people with dry.
No, it's for everybody.
For everybody.
But I specifically counsel people with dry AMD that are on primary prevention to talk to their primary care doctors. That's as much as I have a handout I give them. I do not tell them to stop it. I say, take this handout to your primary care doctor and talk about it. I have studies referenced.
So it doubles the risk of getting dry AMD then wet AMD.
No, it only doubles the risk. Here we go, statistics again.
Because,
It's a good point. So people that were taking aspirin had a double the risk of developing wet AMD compared to people that weren't, and they didn't look at whether they had underlying dry AMD or not. But that is a really good point because I think that population already has a high risk of developing wet AMD, and so you might even more than double it for them, right? So anyway, not enough time. So moving along, diabetic macular edema, very complex. Don't even get me started on this. I use rise and ride criteria for eligibility. We don't have time to talk about that. And it's time lenient and forgiving. I'll just say briefly, wet AMD, if you don't treat within a couple of weeks, they're really losing vision permanently. DME, you've got time to counsel. Was it your patient? Yeah, yesterday. I saw your note. That jackal, I know. Yeah. All right. Okay, so we got a regmatogenous RD on the left, and we have an exudative RD on the right. Okay, so which is more emergent? Everybody says, yay, regmatogenous. All right. So consult Retina ASAP, and consult me. Don't consult the other guys. All right, I'm just playing. So Dave Kim did want me to specifically say, don't tell the patient they need surgery within 24 hours. This isn't you guys. This is actually outside people. But do tell them to fast just in case. Because the last thing a retina guy wants to do is be ready to go hang out with his family for the weekend, and then a MAC-off RD comes in saying, hey, if you don't operate on me within 6 hours, I'm suing you. Anyway. And then don't stop looking after you find the first break. You'll really impress us if you find the second and third breaks. Look for vitreous hemorrhage, PVR, macular involvement, things that have, and then pseudophakic status, things that have implications for approach. CSR, I'm just going to fly through this. Get a sleep study. Please get a sleep study on everybody that has CSR. Most of my patients also already have sleep apnea, and most of them don't know it. I had a patient, gosh, don't have time for anecdote. Just do it. Get a lot of studies, photos, and actually OCT and FAF are going to be the most helpful. FA and ICG I'll do when I'm considering surgical planning, or not surgical, but intervention. And then I do PDT. I do thermal laser for some people, and I do PDT for folks that are chronic, that have a recurrence. I don't wait for them for 4 weeks. But if they've never had an episode before, I'll usually sit on them for a little while. And they usually, if they're acute first episode, they've got time on their side. So this is Plaquenil toxicity on this side. It's technically a bullseye maculopathy. You don't know it's Plaquenil. There's nothing specific about it, and that's a choroidal nevus, which is more common. Sorry, Tamana. Plaquenil toxicity, these are the risk factors you probably all know. I want them addressed in your notes. This is more the nuts and bolts of running a clinic now. I want you to talk about, do they have greater than 5 years? Do they have greater than a kilogram? Are they greater than 6.5 mg per ideal body weight kg per day? Liver, kidney disease, macular disease. Macular disease is a little bit softer to me. If somebody's got some issues going on in their macula, I might let them stay on Plaquenil because OCT lets you parse them out and differentiate which is which. Elderly, I just saw that. I didn't even know that was one of the risk factors. So if you're old and Plaquenil, good luck. You do need to do an ocular exam, 10-degree visual field, autofluorescence, OCT, multifocal ERG is only for tiebreakers for me. You will have a few people that have some weird things that show up on their 10-2 that may not have a whole lot on their OCT. So those are the ones I'll send for multifocal ERG. More housekeeping, yes.
For a baseline, do you also do the fundus autofluorescence? Because I
Oh, I
tried
see
that
what you're
with
saying.
somebody and,
They are
and
just
were like,
starting.
Why are you doing that?
You don't have to. No, I might if there's something else going on in their fundus. I think it's if you do need one of the big three even at baseline.
Okay.
So you pick one of your big three, and according to our practice guidelines, you only have to see them once when they start and then 5 years later. But we don't do that here. We do every year. I want you to document size in millimeters on choroidal nevi, not disc diameters. That's a style point. And then TFSOM, what does that stand for?
Too fine, small, ocular.
And then the T stands for.
What did
That's
that
good. No,
stand
I
for?
no. I want you to get that because that's a mnemonic. TFSON doesn't really mean anything. To find small ocular melanomas, the T stands for. It's really a so thickness. F is for fluid. S is for. It's the hardest one. Symptoms. Ah, see, we already had the fluid. And then O is orange pigment. M is margin. How far from the disc is it risk? 3 millimeters.
3 millimeters.
So if you're less than 3 millimeters from the disc, you have a higher. It's a risk factor for growth. So we're talking about risk factors for growth. So if you document 2 or more of those, or if you have photographic documentation that it's enlarged, send to ocular oncology. They may or may not treat it like a small melanoma, but then it's in their playground. Okay, 1 out of 9,000 will transform to melanomas. I bet that's a under estimation. I think it's probably higher than that. At least I've seen a few, and not since I've been following them, but started out at Wilford Hall like 10 or 15 years ago, and now they've got a melanoma. Okay, and then get the autofluorescence and OCT every time they come in. Get a photo every 2 to 5 years. This is diabetic screening clinic. This is based on Aaron's recommendation. We got 3 minutes to get through this. When you're in diabetic screening clinic at Wilford Hall, it's kind of like cattle call. Everybody wants glasses. Nobody's going to get them, and you just kind of have to push through. Sorry.
Truth.
So what do you need to ask about? There's only a few things you need to ask these people. This is the eye is a window to the soul when it comes to diabetes. You know everything. You don't even need to talk to them, right? But if you're going to talk to them, it's nice to know their age, pregnancy status, do they have type 1 or type 2, duration, hemoglobin A1C, symptoms, medications, medical history, ocular history. I find that those things are better to ask if they actually have something going on in their eye. But I do document the A1C. What do you need to look for? Well, everything, but specifically microaneurysms, all these things on those list. I will specifically document NV. I'll specifically document macular edema. I'll specifically document PVD status. And then there's one other one. I'll talk about their blood vessels if they have any AV nicking. So I don't document no NFL infarcts or capillary non-perfusion. And actually, capillary non-perfusion is a tough call without FA anyway. But those things are important. PVD status is important because, for me, if they have a PVD, they're probably not going to develop. They're definitely not going to develop a TRD. So they might get some macular edema, but most likely they're going to do pretty fine, and you're not really ever going to need to treat them. So this is normally a first-year question. When do you need to do your first eye exam with diabetes type 1? 3 to 5 years after. We do them all diagnosis because we're the military, and then yearly. And a second, diabetes type 2 is at diagnosis because they probably started years before, right? And then sometimes you like to see people with PDR at the time of their diagnosis. But you're right. Diabetes type 1, type 2, nowadays we look at I see so many pre-diabetics, it makes me want to go out and hang myself. It's like, come back when you actually have a diagnosis. I mean, it's hard enough to look at normalized for two people that have had diabetes for 30 years, you know. Somebody's had it for like -5 years. Come on. So pregnancy and diabetes, you need to see them prior to conception, early in first trimester. If they have diabetic retinopathy, you can't see all of that. You want to see them very closely. If they've got severe or worse, you need to see them every month. Okay, so here's our spectrum of diabetes. Have any of you guys seen this? I've shown it to like 2 people, I think. I made this years ago and kept on forgetting to show it to people. What percentage of people with no diabetic retinopathy will get it within 1 year? Anybody know? It's very low, 5 to 10%. If they've got, what's the definition of mild? There's 2 different classifications, by the way. I'm going with the easier one. The other classification actually has a classification called MAs only before it gets to mild. I think MAs only is a great way to define mild. What percentage of these people will get mild? With mild and PDR will get PDR. This isn't worth memorizing. 16%. I should take it off. Okay, so here's how I define moderate NPDR. Does anybody know the definition of this?
I know not the definition.
More than one MA, but
No,
less.
I got in trouble with it. You got me for that. 'Cause one time,
That's what Dr. Pierce.
Right.
'cause
Oh,
Drew-
sorry. Whatever
okay.
Dr. Pierce told you doesn't count anymore. She's gone.
Because the guy had
She gone.
The guy had 3 MAs that I found, and I signed the note to you and wrote moderate NPDR.
Oh, that sounds like me, yeah. And
Drew
I was like,
it's
no,
not
no, no.
moderate. And I was like, but Drew said there's more than one. it's moderate.
So you can have a bazillion MAs for all I care. It's still mild. If you have severe NPDR, it's severe, and we'll go into that definition. And if you have something in between that, it's moderate. So that's all moderate is. More than mild, less than severe. It's easy, right? It's easy. But you do have to know what severe is. And who am I going to call on? Let's see. Any first years want to raise your hand? All right, go for it.
Isn't it the 4-2-1 rule?
It's a 4-2-1 rule. What's our 4?
So that's, I think 4 quadrants have more than 20 dot block hemes. 2
Good.
quadrants with any sort of venous beating.
Good.
I can't remember the one now.
It's like a a lady from Mexico. It's her first name. She's Tejana. Irma.
Irma Tejana.
I'm not gonna be able to put this on YouTube. So intraretinal microvascular abnormalities, and there's one. I'll show you a good picture because people used to always say, "I've never seen it before. I don't know what it looks like." Okay, so 4-2-1 rule. Here you go. You said them all. You did great. Well, you didn't get the last one, but you did great. So 20 plus intraretinal hemorrhages per quadrant. There's those sausage links, the venous beating, right? And that they used to call them Chinese characters, so that's probably not PC anymore either. Those little kind of squiggly things, you see those right in the middle? That's kind of Irma. Irma can also kind of look like flat NV. There's always this debate. Is it flat NV? It's more like this. Okay. Yeah, maybe.
Yeah,
Maybe.
definitely.
Okay. All right, we're out of time, but I'm going to finish this. Okay, what's the prognosis when one of the 4-2-1 criteria is met? Oops, sorry, I'm reading off the next slide. So you get one of these. What's your prognosis? To go on to, let's say, what's your chances of going on to PDR HRC? 15%. Yes. All right, and this is called severe NPDR. So if you have 2 of these, we call it very severe, and what's your chance of going to PDR HRC within 1 year? 45, so it triples, right? This is worth knowing because this will help you decide when to see the patient next. We're going to go over that too. And that just gives you a good sense of how this stuff progresses typically. So PDR is defined by proliferation, which is neovascularization, preretinal hemorrhage, or vitreous hemorrhage, right? So we break this down in 3 categories. I used to ask people questions as to what these are. No HRC, HRC, and advanced, right? We always talk about HRC. But does anybody know what HRC is? High-risk criteria?
Like the 1/3 of the NVD.
1/3 to 1/4 of the of NVD by itself, right?
Without
Counts as
vitreous
one.
heme.
And then
Any NVD with vitreous heme.
right, that could be a second one, and the third one is
NVE with
how much NVE?
1/2.
1/2 of a disc area of NVE plus vitreous hemorrhage. So any one of those counts as high-risk criteria, right? There's another way to call it PDR HRC, but this is the easy one to remember. Advanced PDR is basically you can't grade it due to really bad vitreous hemorrhage. You've got ptysis or you've got a TRD involving the macula. Not as important to know that, but it is in the book. So management, this is again diabetic clinic style. We're not going to get into specifics. No diabetic retinopathy. Don't ever come back. I wish. Come back in 1 year. Come back when you lose vision. Mild NPDR, follow up in a year. Moderate, 9 months. I could go with a year. Severe NPDR, I want to see you back in 4 months. And I want you in my retina clinic. And then the PDR, we got to educate and treat. So what do I tell people in my really quick cattle call diabetic clinic if I get stuck in there? They got another A1C. I will take a little Post-it, write A1C on it and say, this is your homework. I don't care if somebody told you it was fine. I don't care if you've had diabetes for 50 years and you still have no clue. You need to know your A1C. This is 2014. Come on, get with it. In fact, in Philly, they started putting up at the bus stops, you know, it said something like, had this picture of a guy sitting in a lounge chair with like a bus coming through the wall. He's watching TV on an old cathode ray tube set. And it's like, Frank, do you know what your A1C is? It's your diabetes is coming for you. And it's like this bus crashing through. I'm not making this stuff up. I got to find that picture. It's somewhere. I was like, go Philly. So got to know your A1C. Tell them what it is because they all go, my A1C, oh yeah, it's 230. Or, oh yeah, I took it this
Yeah.
morning, it's 170. You got to explain it to them. Remind them these comorbidities, there's 5: high blood pressure, high cholesterol, anemia, congestive heart failure, and then kidney failure. All make diabetes worse. Anemia is the one that will always make their diabetes worse. And you're like, why is your diabetes so bad? Your A1C is 5.3. And then they're bleeding out from some GI thing. So teach them, they need to come in for their exams. They can't skip them, even as much as I'd want them to, because we're going to pick it up before they have any symptoms, right? If you see severe PDR or DME, we didn't even talk about DME in here, send it to the retina clinic soon. And 2 major risk factors for developing retinopathy. I won't even ask you guys. Duration of diabetes, severity of hyperglycemia. These are just weird questions from the book. 2 medical conditions that are associated. I mentioned the 5. 2 of those are really associated. Hypertension and dyslipidemia with worsening diabetic retinopathy. How often should women with gestational diabetes be examined? Does anybody know? Gestational diabetes, how often should they be examined?
It'll depend on your findings, right when they get pregnant.
Well, it's a trick question, actually, so. Never. How many times does somebody come into your clinic for gestational diabetic eye exam? Never. Thank goodness OBGYN has figured it out. Never send a patient to ophthalmology, right? Unless they have problems. But so if they have type 1 or type 2 before they get pregnant, that's totally different, right? They need to be seen frequently. But if they just have gestational, they, assuming they don't, I don't know if you can go from gestational to full-blown permanent diabetes. You can, but it's probably not that common. Okay. So that's it. Sorry, we went over. I'll try to put this up on my website soon, assuming it records correctly. If you guys have questions, ask me. Thanks.